session is open for any questions from the audience. So I have one question for Dr. Farooqi. With very nice presentation regarding hepatitis B, but regarding that yellow area, the yellow zone area where the DNA levels are not matched, ALT levels, they are not up to the for treatment recommendation. What about if someone has along with the Hep B in this group, along with fatty liver, like the MESLD? Until now, no guideline mention about this part. So what are the recommendations if someone has the fatty liver and fall in this group?
Yeah, thank you very much. Very relevant and very practical and clinical question. Yes, and this is a scenario which we mostly come across. The WHO guidelines did recommend that you start these patients on antiviral treatment, and we discussed this a lot. So if it's only the fatty liver and otherwise it is okay and there is no fibrosis, F0 or F1, that probably we can wait on that, because we discussed this point. When you see this algorithm, what we saw today, this is not what we made this 2 years ago. We had a lot of discussions on it, and Zegam was an opinion that if we include that, that probably the canvas will be so much expanded that probably it may not be, but it should be individualized. Of course, the final decision is by the patient. But I personally think when it's a fatty liver and the high risk, the cardio metabolic risk factors are there, and there is other scenarios, so that patient may be considered for the antiviral treatment. But because that is the yellow or the gray zone areas where you may make decision for one patient to go, and for another you may say wait. So that's the very good point, and needs to be thought twice before starting these patients. So first I'll personally do that. Even we'll try to treat minimize the risk factors and treat the weight loss, all those things, and then we can. Thank you.
Thank you so much. So probably by the next year, it may be including some of the guideline, right? So any comments from the chairs, to conclude the session? But before, one question here, sir, please.
So again, thanks to Firosans and thanks to Farooqi Bhai, and we have Dr. Altaf and so many luminaries. We'd like to, get some input from them also. Hep C and Hep B co-infection. We recently at our clinic had a patient, HBV, at the time of initiating HCV-DA treatment was negative. This was a patient with the ALT modest range, 45, 46, intermediate sort of HCV count, and we went ahead with the HCV treatment because the HBV PCR was negative. Following successful eradication, the ALT has slightly yo-yoed. It is going up and down. The HCV following DA has remained negative, but the ALT rises, drops a little, then rises. So how often do we get the HBV DNA to check for relapse? Because when we checked, there was some suggestion in the literature that following eradication of HCV, HBV can sort of resurface. So just, comments from everyone. Thanks.
There are theoretically 4 possibilities. One is both are inactive, either C is active, B is inactive, or B is active, C is inactive, or both are active. So when both are inactive, of course, things are simple and you follow them up. When B is inactive and C is active, the general recommendations, and this is one of the guidelines as well, initial one, that when you treat the active hepatitis C during that treatment and 3 to 6 months after the end of the hepatitis C treatment, you give the prophylactic hepatitis B treatment as well. That was one thing, because the cases were reported that while B was inactive and you treated the C, the B was reactivated. So one is that. Second is, of course, when the C is inactive and you treat the B, cases, to my knowledge, no cases have been reported that C has become reactivated. So, but for that, when the patient is having the B dormant and C is active, what I do personally in my clinical practice, I do give them the hepatitis B treatment for 6 months after the end of the hepatitis C treatment. And when that, I don't check in routine the PCRs every 6 months, but if there's a high risk, he's in that group where we didn't start the antiviral. So at least all B carriers, we check the PCR, the ELT 6 months. I personally check PCR yearly. I don't check every 6 months because of the cost and all those things. But for this particular scenario, when B is inactive, C is active, I personally give cover to the prevention of the B reactivation. I'll request Altaf Saab what he wants to say.
Yes, sir. I also, even if DNA PCR negative and HCV PCR is positive, I would treat both. And there is no indication for treatment of HBV. I will stop it 3 to 6 months down the road once hepatitis C treatment is finished. And this is included in the guidelines. On a personal note, Dr. Asif, I would treat MASLD and so-called indeterminate HBV today.
Yes.
Because this comes in the domain of shared decision making, which to me is my decision in Pakistan, because only 1 to 2% of my patients understand the disease pattern, their natural history and all that. And if they do, you tell them that there are 2 fires burning instead of 1. So the risk of damage is higher and earlier. So I would treat you with indeterminate B, but with
Lifestyle.
with MASLD. Whether it is F0, F1, I don't care. So we'll treat for that and take MASLD on merit as we do normally. So,
More aggressive.
thank you. Yes, yes. And some of the guidelines are now clearly mentioning that in addition to co-infections with B, C, HIV, etc., that you should treat in the presence.
Yeah, I think I agree. Fundamentally, what you basically want to do is prevent the damage to the liver. And if there's already damage to the liver, then you have to do whatever treating B as well as MASLD. So I think personally, if you have a DNA which is there or not there, but if you have a liver damage, in any case, F2, F3 would come in the treatment category. So fundamentally, any evidence of liver damage or inflammation, you just treat.
Thank you, sir.
To me, the liver damage will be fibrosis.
Yeah.
Yeah, liver biopsy may be a good thing here, but that's the reason we say that this is the individualized approach, and of course to the patient and all, and to the caring physician, and how much motivated the patient is for regular follow-ups and all those things.
You will only do a biopsy with the question
That you have to answer. So mainly for autoimmune. But for B, for C, for MASLD, now even the FDA, Bilal showed that slide, that they advise to do non-invasive monitoring and start treatment based on non-invasive monitoring. So why do a liver biopsy? Except where you suspect either SOL or superad in autoimmune.
Yes, everyone has mentioned that biopsy is getting less and less, but autoimmune hepatitis is something we all have seen, and I think that if you have to pay attention to the liver enzyme and you start the treatment, liver enzymes are not big